As a gastroenterologist, I look at this as having three different disease processes, but the Venn diagram comes together: IBS, leaky gut, and diet. So, this is an IBS SIBO summit. Let's look at IBS. As a gastroenterologist, IBS actually affects 20% of the US population. Over $30 billion a year are spent on this. Unfortunately, the diagnostic criteria is pretty minimal. All you have to have is pain, change in bowel habits, and if it lasts more than 3 months, then you can be labeled as having irritable bowel. And unfortunately, even the most common symptom that I see with this, which is bloating, isn't even included. So this is like a trash can diagnosis. There are other trash can diagnoses also, and we're going to talk about that in a moment, and you're going to see this overlap of what's going on. But what we know is that for years and years and years, people have been treating irritable bowel syndrome with antidepressants. They've been saying it's all in your head. I see patients all the time that they go from doctor to doctor. They get an endoscopy and colonoscopy, perhaps many of them. And when they wake up in recovery, the doctor's like, good news, you just have irritable bowel syndrome. That particular patient feels just as bad as they did before they came in, and now all they have is a label. And once you get labeled as having irritable bowel, in my opinion, people quit thinking, or at least people in private practice like me, busy doctors. So we're right here where we were 30 years ago. The fact that bacterial overgrowth has been discovered as causing these symptoms is exactly where we were with peptic ulcer disease over 30 years ago. And it took an Australian gastroenterologist to actually swallow Helicobacter pylori and create an ulcer in himself to prove that bacteria can be the root cause of this. This is no different than what's going on right now. So if we think about this, the human body works very hard to keep most of the upper digestive system relatively free, or at least decreased amounts of bacteria. So in the duodenum, it should be relatively sterile due to gastric acid, bile salts, pancreatic enzymes, and so on. And the motility moves very quick. That's where you're going to start the absorption of food. But we know that the microbiome is extremely important. So what I tell my patients is, it's not so much that bacteria are good or bad, it's that they need to be in the right place. So we know that there are 100 trillion colony-forming units and greater than 1,000 species in your microbiome, which most of it should be residing in the colon. Now, we know that that is a genome within a genome. The real movement right now is, do we exist for them? Do they exist for us? What we do know is that probably our society and the way that we live and the way that we eat is not treating this very important genome within our genome the right way. So, the way that I describe bacterial overgrowth, let's look at a video of what's actually going on. What I tell my patients is, when you actually have an infection or get sick, go through a very stressful event, possibly even take antibiotics, anything that can affect the motility of the intestines, bacteria can start to grow there. Nothing new here. Then when you eat starches, those bacteria will produce hydrogen gas. If the hydrogen gas becomes of enough sufficient quantity, then we start attracting these methanogens, Methanobrevibacter smithii. What this little guy does is he takes in and he soaks up the hydrogen, and then through an enzymatic process, the methanogens actually produce methane, hence the name. This was really exciting discovery that Dr. Pimentel, I believe I'm going to coin him as having the first person to at least tell me about it. So whether it is whether he was the one to do it or I was the first person to hear about it, he had actually come to Dallas and gave a lecture about this, and I thought it was the most fascinating thing ever, and that's how I really got interested. And we're talking like 10 years ago at this point. So we know that methane's being produced. So what does the methane do? Well, the reality is that methane works as a local paralytic, or it slows everything down. So now we have a model for IBS-C, IBS with constipation. The more that the methane slows everything down, the more bacteria grow, the more methane produce, the more it slows it down, the more it allows to grow. This is why when I talk to my patients, they'll be like, I was perfectly normal, and then I traveled to Mexico and I got really sick there and I've never been right since. This is that model that explains, oh, now we've got a self-serving model that causes more bloating, gas, constipation. Now, not all of the methane is going to be absorbed. About 20% gets absorbed, so 80% is going to go to the colon. This explains why it'll actually slow the colonic movement down as well. So when you compare IBS plus the percentage of people that have constipation, that is a huge percentage of the U.S. population, 47%. That's how come pharmaceutical companies are so excited to try and find something to help these people. So what about diarrhea? That's what everybody asks. Well, diarrhea, we now realize, is actually caused through a similar mechanism, but hydrogen sulfides being produced. And I do know that some of my research colleagues are working on developing breath tests and different things to look for hydrogen sulfide. But for me as a clinician and with a busy practice, now I have a model to explain IBS-C and IBS-D. One of the problems that I always had was that people were labeled the same diagnoses with opposing symptoms. It's very odd to me. And so I've always tried to figure out how to separate the two, and now we have a reason. Methane constipation, hydrogen sulfide diarrhea, and then the mix of the two creating possibly an IBS mixed. Now, this is what I'm seeing a whole lot of. What else has SIBO been linked to? And I think this is the future of where this is all headed. I have seen people get better from all of these different diseases. And on the right side here, we're going to call these functional diseases, trash can term diseases, so on, where people just get labeled. Depression, fatigue, sleep disturbance, migraines, chronic pain, fibromyalgia, interstitial cystitis, pelvic pain, prostatitis, restless leg syndrome. But now we're seeing very objective things: rosacea, acne, coronary artery disease, fatty liver, non-alcoholic steatohepatitis, diabetes, and even obesity. So this is no longer something that we can just say, oh, it may or may not exist. We know that it's probably creating a lot of different problems. Now, I know that other doctors have talked about how to diagnose this, and unfortunately, we just don't have this perfect test quite yet. IBS Smart, looking at the vinculin and CDTB antibodies. I'll defer that to the guys that are really good at that, like Dr. Pimentel. Jejunal culture, somewhat invasive, a little bit variable in sensitivity and specificity when you look at the data, but I will defer that to what I would consider the country's expert, Dr. Satish Rao, on that, one of the few people that will actually do that. So now we're left with the one that most people do, which is breath tests. And we know that there's probably a significant variability in the sensitivity and specificity of these breath tests. In fact, there was a consensus statement in the American Journal of Gastroenterology in 2017 that stated there is significant heterogeneity in test performance, preparation, and the indications for breath testing and the interpretation of results. So in my practice, I see people that have come in with multiple breath tests from many different labs. So I'm not knee-jerking in breath testing. If you're going to Cedars-Sinai and they calibrate their machines and all the time and they make sure, then I would trust that a little bit more. But I do have a lot of people that just do at-home breath tests, and we don't really know if all the parameters are being controlled. So what I tell my patients by the time you come to see me, if you look like a duck, quack like a duck, and walk like a duck, I'm going to try and treat you because you've already spent a lot of money and you've already had these other tests done. You're very classic for what I would consider somebody that has bacterial overgrowth.